for being here today. My name is Jennifer Blank, and I will be presenting today with Dr. Sarah Kopelovich and Trez Buckland on an evidence-based training for families and caregivers of a loved one with psychosis, known as Psychosis REACH. Before we start, I do just want to let you know that there will be a Q&A box on the right side of your screen where you can enter questions throughout the presentation. And then at the end, we should have plenty of time to discuss those more. And then also at the end of the session, you'll see a session survey, and we would really appreciate if you could just take a minute to fill that out. So again, we are really honored to be here with you all today to share a relatively new training program that is currently being scaled up in the United States, known as Psychosis REACH, which stands for Recovery by Enabling Adult Cares at Home. This training program is really unique in that it takes place outside of the clinic and in the community. And it provides evidence-based training to family members in cognitive behavioral therapy for psychosis. So throughout our presentation today, we're going to start by presenting some evidence that support a training like Psychosis REACH, and then we'll walk you through our current Psychosis REACH model. We're also going to describe our newly developed family ambassador role and talk about why this is such a critical component of the Psychosis REACH model. And then finally, you will hear from one of our inaugural family ambassadors on her experience in this role. So before we begin, I just want to take a second for us to introduce ourselves. Again, my name is Jennifer Blank, and I am a research coordinator at the University of Washington in the Spirit Lab, which stands for Supporting Psychosis Innovation through Research, Implementation, and Training. I am also the event coordinator for the Psychosis REACH training program. And I also have with me today Dr. Sarah Kopelovich, who I will let introduce herself.
Good afternoon, everyone. It's good to be here with you today. As Jen said, my name is Sarah Kopelovich. I'm a clinical psychologist by training and an assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington. My area of focus is in enhancing access to evidence-based psychotherapeutic interventions for individuals with psychotic disorders and for family members seeking care. And so most of my work really focuses on enhancing access specifically to cognitive behavioral therapy for psychosis. My role in Psychosis REACH is as the implementation lead.
Thank you, Sarah. And then also with us is Trez Buckland, who I will let introduce herself.
Hi, my name is Trez Buckland, and I am an educator by trade. I taught middle school and high school for 25 years. My son was diagnosed with schizophrenia when he was 16. At that time, I transitioned to working at the University of Washington in the School of Nursing and School of Public Health. And I went back to school and earned my PhD in nursing, studying social support systems for young adults with psychotic disorders. I currently am retired, but I enjoy being involved as a volunteer with NAMI, the National Alliance of Mental Illness, and I'm really grateful for the opportunity to work with the Psychosis REACH program.
Thank you so much, both of you. We also want to recognize our colleagues in training, our Psychosis REACH training co-developers, Dr. Kate Hardy, who is a licensed psychologist at Stanford University and who has led multiple trainings and workshops in CBT for psychosis to a wide variety of audiences, including family members. And then also Dr. Douglas Turkington, who is a psychiatrist and professor of psychosocial psychiatry at Newcastle University, and who actually developed and over the last 30 years tested CBT for psychosis. We have been incredibly fortunate to have worked with both Drs. Hardy and Turkington over the past 3 years to really develop what is our current Psychosis REACH model, as well as our implementation model. Okay, so let's jump into our first objective, which is reviewing the evidence supporting a training for caregivers, and then walking you through the Psychosis REACH model. So to begin, we know that recovery is most likely to occur with holistic, multidisciplinary, evidence-based, and culturally sensitive care. And in fact, our national psychosis practice guidelines recommend comprehensive multidisciplinary care that includes a range of interventions and supports. And so this includes evidence-based psychotherapy, evidence-based pharmacotherapy for those who respond well to medication, case management. There's also a lot of evidence and emerging support for services such as peer support services, as well as educational and vocational services. And then, of course, this family intervention piece, which typically includes family psychoeducation. And so this model that you see on your screen, it looks similar to the coordinated specialty care models that are currently being applied to early psychosis, as well as to individuals who are in high-risk states. And so really, this is the ideal model that we hope to be seeing implemented as this standard of care across all stages of the psychosis spectrum. And so diving back into this family interventions for psychosis piece, we know that caregivers have a positive impact on the recovery of their loved ones with psychosis. And in fact, the evidence base that details the efficacy and the effectiveness of family interventions is well established, and it's been reviewed extensively. And so we know that when families are involved in treatment, we're seeing better treatment outcomes for their loved one, as well as fewer hospital admissions and reduced relapse rates. And with regard to this point, there was a study done in 2014 by Knapp and colleagues that found when support was extended to family members, relapse rates were shown to have been reduced by as much as 40%. We are also seeing shorter inpatient stays when loved ones are involved in treatment, as well as an overall improvement in quality of life, better work and role performance, as well as reduced substance use. And with regard to this last bullet point, there was a study done in 2015. This was actually a 10-year longitudinal study of first episode psychosis service users that found when family was involved in treatment, risk of unnatural death in service users was reduced by as much as 90%, which is huge. And so as you can see from this slide here, there's an extensive literature base that supports family interventions for psychosis. And yet, we're really seeing that involving families in treatment is a radical departure from the status quo. Despite the fact that a majority of adults with chronic delusions and other symptoms of psychosis live with a family member and often request family involvement in treatment, we're seeing that families are not routinely being engaged. And in fact, one study from 2004 found that most mental health providers reported no contact with the families of their patients. And so even though we know that family interventions are effective and they're recommended by our national psychosis treatment guidelines, we're seeing that this collaboration between supports and mental health providers isn't really happening. And this is especially critical because we know that caregivers can spend the equivalent of a full-time unpaid job in caregiving activities, especially when they live far away from the mental health, the mental health system in general. And so what this all really means, of course, is that caregivers are providing more support than the mental health system, but then themselves are in fact receiving little to no support or training. And so we can see that this status quo of not involving family members in treatment is having harmful effects, not only on individuals with psychosis, but on their caregivers as well. And we often see that caregivers are being impacted in numerous areas of their life. So this might include economic impacts due to a loss of work days or potentially needing to relinquish a paid position in order to have the capacity to care for their loved one. We're also seeing an increase in emotional challenges, including depression and anxiety in individuals who are in this informal caregiving role. And then finally, we see that caregivers experience burnout. And in fact, one study from 2006 found that caregivers report burnout and emotional exhaustion at equivalent levels to those that are being reported by paid psychiatric staff. And so what this all means, of course, is that caregivers are in need of support, not only to better care for their loved ones, but to better care for themselves. And so the purpose of Psychosis Reach is really to provide these caregivers with support and with community, as well as to provide them with accurate information on psychosis and on recovery. And then finally, to train them in evidence-based skills that they can use with their loved one to better communicate with their loved one and to rebuild their relationships. And I said this at the beginning, but I just really want to emphasize once again that Psychosis Reach is really unique and that it's taking the family intervention out of the clinic and it's bringing it directly to families in their homes. And so we're going to move into now walking through what our current Psychosis Reach model looks like. And I am going to pass it over to Dr. Sarah Kopelovich.
Thank you. So I'm pleased to provide a brief summary of this Psychosis Reach. So I'll begin by describing the components of the model, and then I'll share a brief description of the approach that we've taken to training families so that we can set families up for success in beginning to apply these evidence-based concepts and strategies. And so I'll talk a little bit at the end of my part here on what we're finding. We've been able to run Psychosis Reach now. This is our homegrown program in Washington State that started in 2019. Despite a pandemic, we were able to persevere and provide the training again in 2020. And we've already provided 2 additional trainings in 2021 with another 2021 training coming up in August. So we've been looking at the data as the data has been coming in, and I'm proud to be able to share some of that with you and also point you to a recently published peer-reviewed article on our findings. So let's think about the model first. You can think about Psychosis Reach as a 3-legged stool that's comprised of recovery-oriented psychoeducation, caregiver self-care, and the first skills. And the first skills are the CBT for psychosis informed skills that we teach to family members and loved ones. So let me just start by giving a little overview of what we mean when we say psychoeducation. Now, we know that according to our national practice guidelines, schizophrenia practice guidelines, which are published by the American Psychiatric Association in the US, the most recently published guidelines were just published last year. They inform us that all families should be receiving psychoeducation about a psychotic diagnosis. What we know from a collaborative interdepartmental committee that was spearheaded by different entities within the federal government in 2018 is that fewer than 2% of family members are actually receiving psychoeducation. And psychoeducation, that should be sort of the bare minimum standard of care for families. We always want to couple that with skills training. But when we talk about psychoeducation for psychosis, we're talking really about 2 things, sort of two buckets. One bucket is just the facts about what does psychosis mean. When we look at the diagnoses that comprise schizophrenia spectrum disorders, what are the criteria? When we use terms like positive symptoms, negative symptoms, what do those mean? Just so that the family members can be more conversant in the diagnosis and these criteria and can know what to be looking for and know what to expect in terms of the ebbs and flow of the symptoms. But the other bucket that's so important with psychoeducation for psychosis is addressing the myths and misconceptions that really contribute to the stigma of psychosis and are pervasive in the media, in lay communities, and even within the mental health community. And so we really talk about how do we understand psychosis with all of the data that we've amassed on this cross-cultural data on psychosis, on psychotic-like experiences, and then how does that inform our conceptualization from, a cognitive, behavioral, and culturally informed perspective about psychosis. And, really with this push to destigmatize psychosis, and also in an effort to ground their hope in empiricism, because there's a lot of doom and gloom out there about psychosis, but there's also a lot to be hopeful about. The second leg of our stool is caregiver self-care. Now, when we use the term self-care, we are referring to traditional notions of self-care, things like nutrition and exercise and setting boundaries. but we're also talking about the application of cognitive behavioral principles to their lives as caregivers to help them manage their own stress. And we know there are high rates of depression and anxiety and burnout in a caregiver population. And so CBT gives us the tools to be able to address those challenges, just as they give us the tools to be able to address psychosis. And so we really want to communicate to families that CBT and self-care skills are just as critical for them as they are for their loved ones with a diagnosis. And then finally, the first skills is about coaching family members in CBT or cognitive behavioral therapy for psychosis skills and concepts. So we want to teach family members these key high yield skills to help them have more therapeutic interactions with their loved ones. We're very clear that they are not playing a role of therapist. That is not their role. So we do a lot to clarify roles and boundaries. And we talk about ideally, even though this is a training that takes place outside of the clinic, that ideally this is these are really strategies that are meant to complement clinic-based services rather than to replace treatment. I want to go into a little bit more detail about the first skills now, because it does comprise so much of the work that we do within Psychosis Reach. Now, we think of first both as a mnemonic, to remember each of these 5 skill domains, as well as a way of communicating to families, try these first. We know that adopting new behaviors is extremely challenging. Any of us who have tried to embark on a New Year's resolution knows this quite well. But engaging in a new set of behaviors when emotions are running high, when there's a lot at stake, is even more challenging. So certainly we know that for family members who are in the throes of a psychotic episode, or who are working with a loved one who's been saddled with debilitating negative symptoms, or is choosing substances over medication, there is a lot on the line. And with all of that, it's even more difficult for us to be our most skillful selves. So the first acronym has this built-in reminder system to try these first. Now, each of these skills builds on one another. So for example, the family often needs to focus on rebuilding the relationship before their loved one is willing or ready to open up to them about symptoms or experiences during the curious questioning or the I skill. But at the same time, you can always, as you progress through the skills, you can always fall back to an earlier skill whenever is needed. So let's review each of these skill domains in a bit more detail so you can start to get a sense of some of the subcategories of the techniques that each encompasses. So first is F, fall back on your relationship. We often talk with families about the fact that you can't do anything helpful from a position of conflict. And in fact, the F skill is calling on decades of psychological research that indicates that the therapeutic relationship is a critical factor in predicting clinical outcomes. And so we are hoping, we need to ensure that we can get that relationship back on solid ground. And there could be a lot of history there that's making its way into, one isolated encounter. And so the F skills could be something that a family member needs to spend quite some time in to be able to get that relationship back on track. And so some of the techniques that we teach families are highlighting strengths and shared interests, activating positive memories that they have, and then looking for opportunities where the family member and the loved one can get on the same page about a shared goal. And that can be quite difficult in this situation, but we work with them to kind of find strategies where there are opportunities for alignment. And then finally, in CBT for psychosis, we heavily emphasize normalization of psychotic and psychotic-like experiences, which we actually know from ethnographic research is quite a bit more common than we previously understood. And I think oftentimes family members and even clinicians are concerned about normalizing psychosis because they fear that they're colluding with psychosis. And so we talk about the difference between collusion, confrontation, and normalization. And Dr. Turkington talks about the fact that normalization is the antidote to stigma. Psychosis is a profoundly isolating experience, and normalization can provide an opportunity to find common ground and help the individual with psychosis feel less isolated. Moving on to the I skill, which stands for inquire curiously. And if we have anyone in the room who's familiar with cognitive behavioral therapy, they'll know this is another term for Socratic dialogue, which is a key hallmark of cognitive behavioral therapy. We really want to encourage family members to ask questions in the spirit of being curious, non-judgmental, and really gentle in their approach, really allowing the loved one to take the lead in what's permissible to ask about. But most people who hear voices, most people who have suspicious or paranoid thinking, they want others to ask them more about their experience. Again, just to kind of break through some of that feelings of being other and isolated. And so we teach them how to ask those questions about their experiences and symptoms, to drop the assumptions. Often the urge for family members, understandably, is to jump right into problem solving. But the first skills really remind us that before we jump into problem solving or skills coaching, we really want to understand better what's going on for that person. The R skill is really about helping the family member, once they've asked those questions and have a better understanding of their loved one's experience and perspective on that experience, to put the pieces together to try to understand what might be contributing to what they're observing. So they might be seeing their loved one, acting in a very unusual, odd, or concerning way. When they can take a step back to ask those questions of, what are you worried about? What kind of concerns do you have? And when you think that that's happening, how does that make you feel? It helps the family member to have a better understanding of what's going on, and understanding breeds compassion. So it's a critical component. We also really want to orient the family members to the role of stress in psychotic experiences, and how, if we can help bring some of the stress and anxiety down, we can actually inoculate the loved one from the psychosis oftentimes, because we know that anxiety and unmanaged stress can exacerbate psychotic experiences. So we think that doing this can really help both with understanding and compassion, but also with helping the loved one get unstuck. Then we'll go to the S skill. Then we proceed to skill development. So we've coached the families to do a lot of work before we're ever suggesting or let alone trying out a skill. We know from the literature, we have 30 years of research now and protocol development in cognitive behavioral therapy for psychosis. There are a number of high-yield skills that are known to help people who experience distress and impairment related to psychotic and mood symptoms. So we want to empower families by teaching them these skills. We want to provide lists of these skills and then give them multiple opportunities to see the skills in action, and for them to start rehearsing the skills and using the language, building that muscle memory for this. And we also teach them how to work with their loved ones, because oftentimes if we say to someone, hey, you seem stressed out, you should really do this, it's really met with rejection. Thank you, no thank you at best. And so we teach them maybe some different strategies to approach that. For instance, when I get stressed out, I really benefit from slowing down my breathing. And I learned this new technique. Can I show you? and tell me, what you think of it. All right, and then let's move on to the last skill, which is the T skill. Try it out and get feedback. So now we're actually at the point where we can work with the loved one to try these new skills out and get feedback on how it's working. And the idea here is that even at best, if the individual is connected to treatment, they really have 167 hours of their week that are not with a treatment provider. And so the family member can really help to coach them, to practice with them, and to really take these from being this sort of thing that you do in therapy to these things that just are part of wellness. It's part of what wellness looks like for them. All right, so I want to share with you now how we train families up in this, because again, we know that family members are very, very stressed. There's a lot going on, a lot of competing demands, and time is precious. And yet we know that this is so important if they can devote the time. So the first thing that we have done in reshaping this model post-COVID is to capitalize on the opportunity to use distance learning. So we took the live training, we put it into a self-paced online course. And now family members have the opportunity to revisit these the course sections as often as they need to refamiliarize themselves with the material. And then once they complete that course, it takes about 5 hours roughly. Then we invite them to a live training. And in that live training, they'll meet with a member of the UW implementation team. They'll meet with one of our Psychosis Reach lead trainers, Dr. Hardy or Dr. Turkington, and they'll meet with a family ambassador. They'll see demonstrations of the first skills, and they'll have an opportunity to ask questions. And then we also, on the online course portal, have a whole repository of resources. We have a community discussion board, which we know will only grow as Psychosis Reach scales up, not just in the US, but internationally. And we also give them an opportunity to connect with this new role that Trez will talk about in just a moment, called the Psychosis Reach Family Ambassadors. So we'll provide them with a contact list. They can select a family ambassador to reach out to do either one-on-one or group format skills coaching, or get emotional support, or get clarification on something that was covered within the training course. We think that this method of doing this, both live and self-directed, self-paced model, is really much more in line with what families want and need. All right, so let me tell you a little bit about what we found to date. So we administer a survey to family trainees immediately before the training, immediately after the training, and then 4 months after the training. And we found a number of really impressive outcomes, considering the fact that this was, really an 8-hour training. What we found was that our caregivers trainees were telling us that they felt less burnt out, that they had less sort of negative associations with their role as the primary caregiver or family point person for their loved one with psychosis, and those reductions persisted 4 months later, even with no intervention in between after the training and 4 months later. They were also endorsing more hopeful, more recovery-oriented, and more optimistic views about psychosis. Things like psychosis is treatable. I want to be around people who experience psychosis. And so we think that this is going to have ramifications for their relationship, of course, but also just in terms of reducing stigma. We also saw reductions in depression and anxiety. Now, I will say that our initial cohort, a lot of them were already connected with NAMI. And so the baseline level of depression and anxiety that we were seeing before the training is lower than what we see at a national level among folks who are not connected to support or advocacy groups. And then we also saw reductions in a construct called expressed emotion. So expressed emotion has been, as a construct, has been around for decades. It is used to refer to the dynamic between a family, typically a family member and their loved one with a psychotic disorder, where the pattern of communication reflects hostility, criticism, or anxiety. And so this is a really important construct because we know that expressed emotion, high rates of expressed emotion, tends to be correlated with relapse risk and rehospitalization for the individual with psychotic disorders. So what this data is telling us is that even with just 8 hours of training, we're bringing stress levels down, not just for the trainee, but we're bringing the stress of that relationship down to a healthier place. And that might also be benefiting the loved one with psychosis as well. We have to look at that next. We also were really curious about whether the trainees were feeling more confident in the first skills and in applying the first skills after the training. And across the board, our trainees self-reported higher confidence in each of these skills immediately after the training. But we found a little bit of a drop in their confidence in their skill set by the 4-month follow-up. And this was a really important data point for us for program development purposes, because this was really the empirical impetus for creating the Psychosis Reach Family Ambassador Program, so that family members who are trained in Psychosis Reach, who have been there and tried that and have gained mastery over these skills, can help to provide that peer skills coaching to new trainees. All of these results have been published recently in a peer-reviewed paper in Psychiatric Services, which is available for download in your dashboard. So I'm going to turn things over to one of our esteemed Psychosis Reach family ambassadors, Trez Buckland, now, so she can describe the role and her work within that role.
Great, thank you, Sarah. So the family ambassador role is really important. It provides 3 things for family members. One is emotional support. Another one is skills coaching, those first skills that we learned in the Psychosis Reach program. And it also provides an opportunity to revisit the didactic teaching of CBTP informed first skills. It also allows people to connect with other families in several different ways. One of the ways family ambassadors can help people is through an ongoing group, which meets regularly. Another way family ambassadors can help is one-on-one, maybe a Zoom call, or it might be a phone call, maybe emails. Or another way a family ambassador could connect with folks would be to do a small group training on the first skills that happens after they've already experienced the training. And you see on the right on your slide that the P-Reach ambassador can help with a variety of different things. So education about psychosis, communication skills, emotional support, self-care, coping skills, and problem-solving skills. So I'm going to be sharing with you my personal experience as a Psychosis Reach family ambassador. And what I do as a family ambassador is primarily work with a small group of people twice a month. What will happen first is after people have experienced being in the training, they'll go ahead and reach out and contact a family ambassador to find out how they can get involved. And so people have typically either called me by phone or they've contacted me through my email. when they call me by phone or through email, I can get some information about their situation, just get to know them a little bit and find out what it is that they really want and need now that they have done the training. And I don't know about you, but whenever I go to trainings, I get all excited and I take my notebook and take lots of copious notes. But after the training, if I don't do anything with it, it gets forgotten. Has a nice warm fuzzy feeling that was really excellent, but gosh, if I don't have an opportunity to practice that and consistently revisit it, it doesn't become part of my repertoire of new skills. So for me as a family ambassador, it's marvelous because I get to practice consistently, which is really good for me. I also have an older adult now, he's 39 this Friday, who has schizophrenia. So I have ample opportunities to practice these skills at home, but it's great to practice them with a group as well. So once someone has contacted me, I know what their wants and needs are. If they're interested in a small group that meets twice a month to practice the first skills, get some emotional support, share self-care strategies and resources, then I know I will be a good fit for them, that the kind of group that I like to do will provide them those things. If they want one-on-one support rather than a group situation, which sometimes people do, then I can refer them to some other family ambassadors. If they want a group and my group's full, I can do one-on-one with them, or another family ambassador can do one-on-one with them until we find a group that is going to be a good fit for them. Within the structure of this group that meets twice a month, we have a couple guidelines that are really important that I let the group know when we start to work together at the very beginning. One of them is that everything that happens in the group is confidential. So we're not talking about what goes on in the group outside of the group. We don't share each other's stories. It's just about us in the group together. Another thing that's really important for my group is they need to understand that because of my career training as an educator, I'm what's called a mandatory reporter, even though I'm retired now. If someone mentions something related to harm to self or others, by my role as an educator, I need to get them help, or I need to try to get them help. So they need to be aware that that's one place where confidentiality might be broken if they're in my group, because if they're talking about harming themselves or harming others, or they're in danger, I need to know that I can help them reach out and get help. And they need to know that too. It doesn't come as a surprise to them. So those are two really important guidelines. Then the way we work as a group, we tend to meet for about an hour to an hour and a half on Zoom. And we have found 4 people to be a good amount of people in our little group. Gives everyone ample time to practice the skills each time we meet. We start out by just doing a check-in, finding out what's going on in each other's lives. Just take a couple minutes to do that, where things are at right now. Once we have gotten through the check-in, then what we do is we use our time to practice the first skills. On the very first meeting, I will give some examples of that using something with my son, with his permission. He is very generous about giving permission to use our personal story in the group, because it's their first meeting and they might not know yet what they want to practice. Once we've had an opportunity to practice those first skills, which typically we do it by role playing. For example, I might come to the session and take my son's role. I would role play him being highly anxious about symptoms he's having from his medications and experiencing his heart rate going up really fast and beating really fast, and then continuing to accelerate his anxiety. And so then he's starting to hear voices. I'll role play that, and I'll give them the opportunity to stop and pause and say, what first skill might you use with them? How might you inquire curiously about what he's experiencing? How might you go back to something in his life where he has dealt well with anxiety or stress and talk to him about how positive that was? So we practice the role play, and as we work in our groups, the family members can bring their own role plays in. And with 4 of us in a group, a family member can role play their family member. And then each of us gets the opportunity to try out how we would respond to that family member. What things can we do to build our relationship with them or to find out more information? What kind of skills might we ask our family member would they like to learn? that kind of thing. Once we have done our role playing in the group, we always end our group, the last about 10 minutes or so, talking about self-care strategies that we found helpful, things we'd like to implement or try to learn in the next few weeks in between our meetings. And if we have any resources to share, we do that. When our meeting is over, I initiate an email to the group saying, here's what I'd like to work on in the next couple weeks, and tell them, and here's something I'm going to do for my own self-care. And then I ask them to respond to the email to the full group so everybody knows what everyone is working on. Then when we meet in another couple weeks, we can pick up where we left off. So that's the kind of thing I do with my group. Right now, my group of 4 people has been meeting since last fall, about October. So we know each other pretty well. We've shared lots of resources over email, and we also reach out to each other in between times if we have a question or something we'd like to work on in terms of the first skills. And it's really neat to see that happening. I always can't be present when we have our meeting. And so all of the members of my group now are feeling pretty comfortable taking the facilitator role. You know, we have a system down for how we work as a team. I also have someone who's just called me recently after our last training, and that person is wanting a group too, but our group is closed right now. 4 is a good number for us. So while we're waiting to find a group for her, she and I are doing one-on-one on the phone. And we just had our first meeting yesterday using the same kind of process that I just described to you. So that's it for me. If you have questions, I'd be happy to answer them at the end of our session.
All right, thank you so much, Trez and Sarah. Before we end, we just have a few resources that we want to share with you all, as well as this quote that you see on your screen right now. That is from one of the family members who attended our first ever Psychosis Reach training in 2019. I just want to preface this quote by saying that Psychosis Reach is not a panacea, but we do see that a little bit goes a long way. And this is especially true in cases where this is the first time that families have been told that recovery for their loved one is possible. And so from this quote, it's quite a lengthy quote, but I just want to highlight this piece in bold that says that this program saved our family. Our life is so much calmer, peaceful now. Through education and CBTP skills, we have our son back. And so again, before we end, we just want to share a few resources for you if you're interested in learning more about the Psychosis Reach training or just about psychosis and caregiving more broadly. I do want to note that you can download a copy of these slides, which contains this resource list, either from the Washington Behavioral Healthcare Conference portal, or I believe that there also is a downloadable version at the bottom of your screen. So this first resource we have listed here is actually our website, psychosisreach.org. There's currently a ton of free information on this page. Some of this includes free training resources from our previous trainings, but it also includes information on upcoming trainings and how to stay informed and how to register. And we have training scheduled through 2022 on our website right now. I also want to highlight a great podcast by Rachel Starr Withers and Gabe Howard, which is titled Inside Schizophrenia. This podcast is really great. It incorporates interviews that feature individuals with lived experience, family members and caregivers, first responders, and other experts. And in fact, Dr. Kopelovich was actually hosted on this podcast a while back to speak about caregiving for schizophrenia. So she talks a little bit more about the Psychosis Reach model in that episode, as well as more broadly about caregiving. If you are interested in that particular episode, it can be found in season 2, episode 15. I also want to highlight this text at the bottom left-hand corner of your screen by Drs. Turkington and Helen Spencer, titled Back to Life, Back to Normality. And this is the second volume of this text. And a significant amount of our Psychosis Reach training materials are actually based on this text. And so we do highly recommend it to families who are involved in the Psychosis Reach training. And then finally, this year, APA will actually be publishing a text by Drs. Hardy and Turkington, which will feature a chapter dedicated to teaching clinicians the Psychosis Reach model and the CBTP-informed first skills. And so once again, please visit our website to learn more about the training. If you have any questions specifically about the Psychosis Reach training or the family ambassador role, please feel free to reach out to us at psychosisreach@uw.edu. And I am going to actually stop sharing my screen now. It looks like we have about 15 minutes to answer some questions. And I did see that some questions were coming in through the chat. So I'm just going to go and look at those. Okay, first, Sarah, I think this is for you. Is it possible to train certified peer counselors in Psychosis Reach and CBTP skills to help make it available, help make the training available to the community?
I really appreciate that question because certified peer counselors play a huge role in the recovery process. It's been incredible to see them being incorporated formally into clinical services. And so there's a couple of ways I want to answer that. So one of the things that I have noted is the inaccessibility of CBT for psychosis it really exceeds the inaccessibility of psychological services for any other presenting problem, psychological condition, and particularly one that does have, the kinds of ramifications that a psychotic disorder can have. And so I have really tried to work to develop different strategies to enhance access. One of the strategies is comes from a global mental health technique called task sharing or task shifting. This is an intervention that traditionally has been administered by clinical psychologists or licensed social workers. We can actually teach other disciplines how to use CBT for psychosis informed strategies. And of course, we're seeing in Psychosis Reach, we can do the same with family members. So yes, certified peer counselors can absolutely be trained in this intervention and can be deploying it in various ways within the community. Within clinical settings, we actually teach certified peer counselors not just the Psychosis Reach approach to CBTP informed care, but also to co-facilitate CBT for psychosis groups. So there are a number of agencies in Washington State that are running CBT for psychosis groups that have trained with my team. And we love when we can have peer counselors in those sessions and talking about their own lived experience using these skills.
Awesome. Another really great question. It's kind of two parts, but would this be an appropriate training for staff at Western State or Eastern State Hospital? What can we do to promote supportive family engagement for patients in state facilities?
Do you want me to tackle that one? I'm assuming?
Yes.
Okay. So it would absolutely be appropriate. One reminder is that we developed Psychosis Reach. The implementation model for Psychosis Reach was intentionally designed so that it would not be dependent on a clinical setting because of that 2% figure that I shared earlier in my presentation. There's a lot of barriers to delivering family interventions. So we don't need to tie it to a clinical setting, but we know that and Western State Hospital and Eastern State Hospital have either expressed interest in adopting CBT for psychosis or have even taken steps toward adopting CBT for psychosis. So we think this is a great all staff training. We really want everybody working in the facility, not just clinical staff, but custodial staff, administrative staff as well, to have more factual information about psychosis, to reduce stigma, and to help everybody have more therapeutic encounters with individuals with schizophrenia spectrum diagnoses. We know from the literature that the stigma around psychosis and schizophrenia is just as bad, if not worse, within the mental health community as it is within the lay public. So I think Psychosis Reach can really help to address that stigma so that people are just getting better, more compassionate care.
Great, and I think that kind of answers the next question too about replicating Psychosis Reach at other sites or needing approval for the training. And I think maybe here it's important to note that Psychosis Reach, the training is now open to everyone nationally and even internationally. We had people attending our last training in May. And so it's open to providing that resource to any family members that anybody's working with really across the country, directing them to our website to get signed up for this training. Another great question is, how does someone become a family ambassador? And I do have a slide that I can pull up, and either Sarah, Trez, or maybe Sarah walk through it, but let me share that slide.
Trez, do you want to jump in first, talk a little bit about your process, and then I can kind of address how the process has evolved?
Sure. So I became a family ambassador because after going through the first training, a question was raised, would anyone like to be a family ambassador? And I volunteered. I think there's 14 of us who volunteered after that first initial training. And as a result of that training, we were then given guidance and training from the Psychosis Reach program led by Sarah. So I think this would be a good place, rather than me talking about my experience, maybe Sarah, for you to come in with this, because that way to become an ambassador has changed a little bit since that first call. So I'll just, other than attending the training first.
Yes, that's an important prerequisite. So we want to make sure that, that in order to teach it or coach in it, that you're really conversant in it first. So absolutely the place to start would be to attend a training. We do have an online application. And because right now we are scaling the model nationally, we are really looking for family ambassadors who have had previous experience facilitating groups. And that could be in a variety of different ways. So we give some examples. We also have an on-demand training course that we've developed for the family ambassadors, as well as a Psychosis Reach Family Ambassador manual. And this is really an attempt to try to standardize family ambassadors' understanding of the role, the limitations of that role, right? What it is, what it's not, how it can look, how it really shouldn't be looking, and to make sure that they're using evidence-based strategies and principles of adult learning to help the families really take up this new material. And then we also really want them to get familiar with the resources at their disposal. So we have video recordings of role plays that they can play with family members, and then even prompts following those video role plays. And then we would ask them to shadow one of our current family ambassadors. What's unique about our current cohort of family ambassadors is that they have received more extensive training than we're going to be able to provide to future cohorts. They didn't have the luxury of things that future cohorts will, like they didn't have a family ambassador manual when they started. They helped craft that manual, but they really did have intense consultation. So after they did actually a 4-day training in 2019 with a lot of skill rehearsal, then they met for 24 months for monthly consultation on how to apply these skills in their own lives, and then how to work with other family members to use these skills and strategies. So we want our new cohorts to shadow them, to see what they do, to learn their, kind of their strategies before they would start their own Psychosis Reach Family Ambassador group.
And Sarah, another question for you. Someone said, it seems that this would also be useful for caring for a person with Alzheimer's. And I'm wondering if anyone has tried with this diagnosis.
Yeah, that's a fantastic question, because we recognize that psychosis is not unique to schizophrenia spectrum disorders. Psychosis is a set of symptoms that's common to several dementias, medical and neurocognitive challenges, as well as other psychiatric conditions. So we do think that the skills will translate, but we haven't tested that out formally. And as a social scientist, I like to make claims that are based on the data. So I know that we had some heterogeneity in terms of the diagnoses of the loved ones who attended our 2019 and 2020 trainings, but they were mostly other psychiatric disorders, like it was bipolar disorder with psychosis. I think we've only had a handful of folks who've joined whose loved ones have a neurocognitive disorder where psychosis is secondary to that. So as we get more folks, we can look at, how are they benefiting? In what ways are they benefiting? And what are they saying in terms of how they might need additional support?
Thank you. And that's all the questions I'm seeing right now. We have a few minutes left, so if anybody else has anything else that they wanted to send in quickly.
I did want to know, I saw a recommendation come through for a novel, Everything Here is Beautiful by Myra T. Lee, describing psychosis and its effects on all relationships in life. So I will check that one out. I'm not familiar with that one. I know that Hidden Valley Road is a novel that's receiving a lot of well-deserved press and accolades right now. It's a very well-researched novel about a family that had multiple children with schizophrenia spectrum disorders. And I read that recently and couldn't help but wonder if that family had been going through their journey now, might things have looked different for them?
Okay, a question that just came in, Sarah, is do you work with people that have drug-induced psychosis? How have you engaged patients to, oh, that's a separate question. So we'll start with that first one, drug-induced psychosis.
Yes, so we really don't discriminate in terms of who we allow into the trainings. We simply ask people to self-identify as someone who loves someone who experiences psychosis. And so we have a lot of folks, we know that drug-induced psychosis and depending on your region in the country, in our region, meth-induced psychosis is a huge problem, is quite prevalent. And so we want to be able to reach this population as well.
And then this next question is, how have you engaged patients to want to involve their family members in treatment?
That's a fantastic question, a really important one. There's a lot of phenomenal work being done in this area in first episode psychosis programs, because we know that one of the most important things we can do when somebody is early in the course of a psychotic illness is to reduce the amount of social disability that occurs, right? By keeping them connected to their people, by keeping them connected to their communities. And so we talk a lot about, again, dropping assumptions, right? So we don't jump into problem solving. We don't presume to know the reasons why somebody might be hesitant or reluctant to involve families. We simply ask those curious, non-judgmental and gentle questions about what their concerns are and what those are based on. Oftentimes people have had experiences that were coercive within the mental health system. And so they're worried that if family gets involved, they'll be forced to engage in treatment that they don't want. They're worried about families finding out things about them. And so there we might be able to talk about privacy and confidentiality, particularly if they're over 18, and if they're not, what that looks like. So again, it's really taking that CBT principle of dropping assumptions, asking about, what their thinking is, what their concerns are, and exploring that gently with them, and helping them also to engage in some problem solving, right? So problem solving is a key CBT skill where we can look at all sides of a problem, explore it together, come up with a solution that, that they think is, most likely to be effective, and then evaluate it, right? So if they have, I actually had a patient recently who was extremely concerned about family being involved. And she was amenable to doing an experiment where we brought mom in. We talked about what we would say in the presence of mom. And then we talked about what was not okay to say in the presence of mom. And we were able to evaluate the belief that if mom had any role in the treatment, that the client would lose all control of the treatment. And she was able to see that that was not a realistic appraisal and come up with a more helpful one that did leave time, did leave room for the parents.
I do want to note that I saw one question come in about a flyer that providers can send to their families. We do have a flyer that we can upload to that Washington Behavioral Healthcare portal that you use to log into today's training. I know that there's some material saved there. So we will upload that into that portal. And if there are any other questions that we weren't able to address, please feel free to just reach out to us at that Psychosis Reach email, which can also be accessed from those slides that are saved in that same place. Also uploaded in that portal is the Family Ambassador contact sheet, as well as a brief one-page summary of the information that Trez went over about her work and the Family Ambassador role. So you can find all of that information all in that one portal. And thank you everyone for joining us today and for the great questions.
Thank you.